Welcome to our webinar. My name is Tracy Cook with Sachs Healthcare Communications, and I'd like to show our audience today how you can send in questions throughout our webinar. Our speaker will try and answer as many as possible at the end of the presentation. Please type your questions into the questions pane on the GoToWebinar control panel. I'd like to introduce our moderator today, Tyler Weiss. Tyler is a Director of Clinical Education for Respiratory Care Services at Rush University Medical Center. He is an assistant professor with a respiratory care program. Tyler is currently pursuing his PhD in health sciences with his research focus on the effect of prone positioning in patients afflicted with COVID-19. He has presented at regional, state, national, and international conferences on various topics related to respiratory care. Due to his efforts in the COVID-19 pandemic, he was named one of Chicago's 2020 Notable Healthcare Heroes, and in 2021, he was named a Fellow of American College of Chest Physicians. Tyler, welcome.
Thank you, Tracy, for the kind introduction. The title of our webinar today is Unplanned Extubation. How did that happen and what can we do about it? Speaking on this very timely topic is my colleague and friend, and one of the experts on the topic, Andrew Klein. Andrew is the Adult Clinical Education Coordinator and Assistant Professor in the Department of Cardiopulmonary Sciences, Division of Respiratory Care at Rush University Medical Center in Chicago, Illinois. He started his respiratory therapy career in 2003 and has been a nationally recognized preceptor for the American Association for Respiratory Care since 2017. A member of the Mechanical Ventilation Domain Task Force at the American College of Chest Physicians, Andrew was recognized as a distinguished chest educator in 2021, 2022, and 2023. He was named a Fellow of the American College of Chest Physicians in 2022 and a Fellow of the American Association for Respiratory Care in 2023. He has lectured locally, regionally, and nationally, and has provided education for the ISRC, AARC, CHEST, and the Society of Critical Care Medicine. Andy discloses no conflicts of interest associated with this presentation. Continuing education for nurses and respiratory therapists has been approved for 1 contact hour of continuing education. At the end of this webinar, you can obtain those continuing education credits. The URL will be provided at the conclusion of this webinar. The accreditation statements are below, and this activity is supported by an education grant from Dale Medical Products. Now I will turn the presentation over to my friend and colleague, Andy Klein.
Thank you, Tyler. Welcome, everyone. I appreciate everyone taking some time out of their day to join us for this topic. As Tyler mentioned, this is a very timely and important topic. I think anybody who's been anywhere near an ICU has had to deal with this, and so hopefully we can close the gap on some things and offer some insight as to what we can do to maybe minimize some of these things. So as we move through today for the next hour or so, we want to talk about what unplanned extubation is and how it really affects our lives in the ICU. And we want to discuss some strategies and some prevention bundles potentially to decrease the likelihood of having unplanned extubations. So first of all, what is an unplanned extubation? I think it's important to talk about sort of what this means. Now, I think colloquially we call this self-extubation, but understand there's a lot of reasons why these tubes get dislodged that have nothing to do with the patient grabbing it and pulling it out. So really it's any dislodging of the endotracheal tube that is not intentional and not ordered by the healthcare team. And so, you know, we think about this, we think about when the patient's being turned, if the tube gets caught and comes out, even if the patient's completely sedated. I've seen this happen. So so we want to look at the whole umbrella of unplanned extubation, not just what we might think of the patient just grabbing the tube and pulling it out as a quote unquote self-extubation. And why do we care about this? I mean, we've probably all seen patients in our careers that, you know, sit up in bed during an SBT and yank the tube out and everything's just fine. And they, you know, they don't hurt themselves. They end up staying off the vent. And, you know, we just kind of chalk it up as, you know, hey, maybe the patient was ready and they knew more than we did in terms of that. But this becomes an issue because a lot of times we can have complications. So what are those complications? Keep in mind that if this tube is functioning correctly, we have a cuff that is inflated, that is below the vocal cords, so that when that tube comes out of the vocal cords, it will pull through there, and it's wider than the space between the vocal cords and can cause damage and swelling. This can cause, if we have a mouthful of secretions when we pull it out, we can have some asphyxia, some pulling fluids and stuff into our lungs. If we're relying on the mechanical ventilator that the tube was hooked up to oxygenate correctly and to ventilate correctly, then we may experience hypoxemia or hypoventilation fairly quickly. Swelling and difficulty resecuring the airway. I can surmise that if you've been in the ICU any length of time, you've had a self-extubation, that when you go to re-intubate, you have all kinds of issues because that cuff coming out of the vocal cords caused a lot of swelling, and it was very difficult to resecure the airway. Maybe you've even experienced having to do an emergency cricothyrotomy in those situations because of the fact that that swelling was too severe. And because of that, because of the difficulty resecuring an airway, and maybe you work at a place that doesn't have some of the experts that can do the cricothyrotomy effectively, death can certainly occur as a result of this, which obviously is the worst thing that can happen. So this is an issue for a variety of reasons. We need to think about this, and we need to care about this. Even if we've had some situations where this has happened that didn't turn bad, count ourselves lucky for those. So how often does this happen? This was a question I had as I started researching this presentation, because, you hear all sorts of things depending on what you read and where you read it, and who you talk to. There's different things that, different numbers that come up. So there was an article in 2004 in the International Journal of Nursing Studies. And basically what they came up with, they looked at a block of time from 1994 to 2002, and they found that it ranged between 3 and 14% of all intubations ended in some sort of unplanned extubation. Of that 3 to 14%, the large majority of those, 78 to 87% of those, were deemed self-extubations, which would be those that we think of when the patient actually physically takes the tube out themselves. The rest of the numbers were accidental, which would be, potentially staff-induced, potentially maybe the securement device failed and the tube came out, maybe some other sort of incidental situation happened that wasn't the patient actually extracting their own tube. One of the studies that was looked at in this paper showed that unplanned extubation was higher in postoperative patients. That may make sense if you think about the fact that these are patients that are maybe a bit more able-bodied sometimes, because they were only intubated for the surgical procedure. They're not necessarily debilitated, so I could kind of make sense of that. And then one study indicated that 43% of these occurred during night shift, which again makes sense because many places have lesser experienced staff on night shift and maybe a less overall staffing model, a shorter staffing model on night shift. And so I could make sense of that. I'll talk about that a little bit as I get into the talk here. And then 77% occurred with no nurse at the bedside. Again, pretty explainable. If there's no one there when some of these things start to happen, the patient starts to reach for the tube. If there's no one there to stop them or to turn up the sedation or whatever the intervention might be, it makes sense that it would be more likely to have an unplanned extubation happen in that environment. So what are some risk factors? What places a patient at higher risk of having this happen? Well, it turns out, based on the data, being male puts you at higher risk, maybe because they're stronger and can overcome the securement device with their wrist and arm strength potentially. Maybe they're strong enough to contort themselves if they're restrained. There's many theories for that probably. Delirium, just overall being confused in the ICU. Maybe you're sedated but not totally sedated, so you're just in a twilight state. Higher GCS scores, if you're more aware that you have a tube in your throat that you prefer not to have, you might be more likely to have that tube come out. This one was interesting to me, and I really dig into this a little bit as we go through the talk, but the use of restraints is a risk factor for self-extubation. That it took me a minute to get my head around that, because I was like, okay, well, don't we restrain them so they won't self-extubate? But we'll talk about that. Patient agitation, that one should make perfect sense. The more agitated they are, the more likely they're going to be, flailing around in the bed, and the more likely that tube's not going to stay in place. Nurse to patient ratios. So some, staffing models require nurses to take more patients, which is going to create an environment where they're not with each patient for as much time, things like that. Which it, creates more risk. And then fixation of the ET tube, we'll talk about that in detail as we move forward, but that's a big risk factor depending on how that part goes. So I created a separate section here to talk about sedation. This is a bit controversial. I can tell you, when I started practicing in 2003, sedation was a big deal, and we sedated everyone. We sedated them to the point where they couldn't even move their eyelids, and if we saw their eyelids move, we just turned the sedation up. -5 was just a starting point. A -5 RASS score was just a starting point back then. We sedated the heck out of everyone. And as we move forward into now into the 2020s, that's becoming a bit more controversial, and we're finding that sedating people may not be the best thing to do if we're thinking about overall outcomes, which is what we should be thinking about. So let's dig into sedation just a little bit. So this one here is kind of known as the Rose trial. This is the one that was done in 2019 in the New England Journal. The conclusions here that these authors came up with, and this was related to paralyzing patients that historically would have just automatically been paralyzed, and they looked at whether or not it had a difference in mortality at 90 days. And you can see here, based on their conclusions, that moderate to severe ARDS, which would be a patient population we would typically sedate and paralyze pretty early on in their course, there was no significant difference in mortality whether we paralyzed them or not with Cystaster curium or Nimbex, than used with the usual care approach of light sedation. So if I think about that, that tells me that maybe, if I'm just paralyzing people because they're really sick, which of course would help me with them not reaching for the tube, but it may not be the best thing to do because it doesn't change outcomes, and I potentially have the side effects of the medication to deal with as I move forward. And so maybe I shouldn't paralyze them. And if I don't paralyze them, then that means that they may be more able to self-extubate. So something to think about. This is from a paper that basically broke down sort of the timeline of all of the sedation-related research that was significant that was done as we moved through the years. So way back in 1995, we came up with the first guidelines for how to sedate mechanically ventilated patients in the ICU. And I don't want to spend a ton of time on this slide. I just want to point out that a lot of work has been done in this area, and a lot of research has taken place to try to guide what the best thing to do is in terms of sedating these intensive care patients, specifically the ones on mechanical ventilation that are very sick. And so we get all the way through to 2021, which is where this stopped. And 2020 is when the COVID pandemic was really rearing its ugly head here in America. And we look at kind of how we manage sedation and what the outcomes were looking down the road. And what we learned in that, and what some of the research shakes out, is that lighter sedation seems to be better for outcomes. Might not be better in the short term in terms of really managing these patients on the vent and making them comfortable, making them synchronous, and all these things we worry about. But in overall outcomes and kicking the can down the road to a month after they're extubated, lighter sedation and getting them off the vent sooner, that seems to be the way to go. The thing is, though, when we lighten the sedation, we create an environment where we might be in that more delirious but not sedated state that puts them at higher risk. So again, something to think about that I wanted to sort of spend some time digging into. And I think sedation guidelines are different institution to institution. Hopefully most institutions base their guidelines on the available data. So hopefully everyone is targeting sort of higher RASS scores. So like -2, -1, more of that calm and cooperative area versus completely comatose like we maybe used to do in a lot of institutions. So hopefully that is sort of the strategy, is to err on the side of, I guess, lighter sedation just enough to make them, the way we want them. Another paper here that looked at early ICU sedation. So in other words, right after we put them on the vent, how sedated should they be? And they found a pretty strong correlation between the depth of sedation and clinical outcomes. In other words, the deeper they were sedated, the worse their outcomes were, which again sort of speaks to the fact that maybe this high level of sedation that we were doing for a while may not be the best way to go. And, on the sort of the negative side of that may create that environment of higher risk for unplanned extubations. So maybe our outcomes are better if we can keep the tubes in. So we may have to explore, and we are exploring ways to keep the tubes in that aren't just turning the sedation up until they stop moving. So this was another paper that looked at finding appropriate analgesia and sedation. And back on that slide a couple slides ago where I looked at the evolution of sedation, there was a point in there, if you look back at that slide, there's a point there where they started looking not just at sedation, but also analgesia combined with sedation. So, our practice at my hospital and at pretty much every hospital I've personally worked at is to have a combination of a sedative like midazolam or propofol combined with fentanyl or Dilaudid or one of the analgesics, and sort of titrate those together and sort of find a mix of analgesia and sedation to keep the patient cooperative. So if we look at this paper here, when sedation is administered, a light level of sedation should be targeted utilizing daily interruptions of sedation with nursing protocols with validated sedation scales. So one of the things I want to point out is what you're going to find as I dig into some of this other literature. What you're going to find is that not only lighter sedation, but sedation that's managed with some sort of scale and some sort of assessment to kind of guide where that patient should be sedated seems to have the most value. So, but you can see a trend here with all these papers I'm showing you that lighter sedation tends to be the more preferred route at this point. So now I want to get into this idea of care bundles. So when we think about ICU critical care practice, we think of protocols, bundles. We think of sort of managing patients this way. We've kind of moved away, I think, just in general from this, let's all stand around as a team and have the doctor just give us assignments to go do, and then we'll all just report back and they'll tell us the next thing to do. I think it's becoming much more common as we move forward in medicine to have some sort of protocol guided or bundle guided approach to a variety of different challenges in the ICU, and then the medical team just sort of weighs in on where they happen to fall on that protocol at that time. So I want to get into this idea of care bundles just so we can sort of all be speaking the same language on what we mean when we say bundles or protocols. So some examples of care bundles that if you work in the ICU, you probably have seen and probably operate on a daily basis. So one of the more, I guess, famous ones here is the ABCDEF bundle from the Society of Critical Care Medicine, originally mentioned in 2017. This is related to weaning, ventilator liberation, how we should manage these patients while they're on the ventilator towards the goal of getting them off the ventilator. Ventilator-associated pneumonia or ventilator-associated event bundles are designed to decrease ventilator-associated events and ventilator-associated infections. And we'll talk about that a little bit. Skin care bundles, this is becoming incredibly prominent in 2024. Managing skin breakdown, managing, doing preemptive work to try to make sure that we mitigate the skin breakdown that may have historically happened. HAPIs, skin-related, device-related pressure injuries, the respiratory therapists that are on the call. We all have to deal with that as respiratory therapists. And then line-related bundles. So anytime there's an indwelling line or catheter, we have to be aware, and we have to try to prevent infections caused by those. Central line-associated blood infections, CLABSIs, is one of the big ones. So let's look at those for a second. So the ABCDEF bundle we just talked about. Big group of people worked on this paper, And they basically dug into the literature and created this idea around what does the literature support that we should do that gives this patient the best pathway towards being liberated from the ventilator as soon as possible. And you see here some of the key points that I highlighted. It's an evidence-based guideline to coordinate multidisciplinary care in the ICU. So most of these bundles are going to cross disciplinary lines. In other words, nursing and respiratory may work together, for example, with ventilator-associated pneumonia or ventilator liberation. There's a role for both specialties, things like that. Assessment of pain and sedation using some sort of scale, coordination of spontaneous awakening and spontaneous breathing trials, delirium monitoring, we'll talk about that a little bit more, early mobility. So all of these things, there's also some mention of nutrition and some other things within this bundle that are very important if we look at getting the patient safely off the ventilator versus, you know, what we're talking about today in terms of unplanned extubations. So this is just sort of what each letter stands for. This is right out of the paper. And these are all the things that really have a role in safely getting the patient off the ventilator. So we look through there and we see all of the moving parts here and why this is such a big topic and a big issue to make sure we get this right. Ventilator-associated pneumonia and ventilator-associated event bundles. This is Rich Calais' paper from Respiratory Care in 2019. Rich is a big respiratory researcher. He works in California. He's a very smart guy. I take his word for any research I see his name on. And this is something that he approached and looked at really from 2013 until they published, and they basically analyzed some of the studies that were out there. And you know what they found was that maybe bundles as they existed when he wrote this paper, you know, they may not be as effective as maybe some of the other bundles that we look at, and that SBTs and really getting them off the ventilator as early as possible and not leaving them unnecessarily intubated was one of the big factors. And so again, you know, we have these bundles, we use these bundles, but some of them are a bit more supported by the research and a bit more supported by the data than others. Doesn't mean we shouldn't use them. It just means we should understand the data that's related to them. So the ABCDEF bundle is very strongly supported by the data. Maybe this one not quite as much. And so here's just some of the things out of his paper that they looked at in terms of, you know, what may be included in this bundle and what the rationale would be for including it. I'm not going to go through this whole slide in the interest of time, but you can sort of see, and you can certainly look up this paper on your own and sort of go through it. It's a really good paper, and it really sort of draws attention to some of the things that that may cause the patient to be on the ventilator longer than we'd like them to be, and how we can try to, you know, think about reducing some of those things. Central line or CLABSI, central line related infections. This was a paper from the British Medical Journal. This was basically a quality improvement report that was published that looked at one institution's sort of journey towards not having any CLABSIs. And they found that CLABSIs are preventable using a multifaceted or bundle approach, if you call it that. And resulted in a significant reduction in CLABSI rates in their ICU. And so they formed this bundle, they utilized this bundle, and they, I believe it was 741 days. I'd have to look back, but it was 700 plus days that they had where they had 0 CLABSIs in their entire ICU setting based on this bundle. Then they, I believe, had 1 or 2, and then they had another several hundred days. So very effective, and it bundled a variety of different things that all of which have individual value, but then if you bundle them together, had great value in this very big problem that they and other places I'm sure had. So now, how do we bring this all together with unplanned extubation? How do we bring together all of these things and all of these moving parts that have to do with unplanned extubation how do we bring these together and maybe bundle and create an idea around at least bundling some of these ideas together to try to minimize this from happening. So this was a paper that came out last year that was basically a review of systematic reviews. So anybody on the call that doesn't speak research, when we think of sort of the hierarchy of research and what makes really good research, randomized control trials happen. Then we do systematic reviews of many randomized control trials. So that would be one systematic review. And the systematic reviews have more value than the individual randomized control trial because of the fact that they applied statistics to the whole group of randomized control trials. So what this group did is they did the same thing with only systematic reviews. So sort of imagine even another tier of research. So this should be considered very high level research. So let's talk a little bit about some of the things that they found and sort of how we can maybe bring this into this idea of, you know, how we minimize unplanned extubations and how we might bundle some of these ideas together. So they assessed risk factors and preventative measures, and they found 20 pieces of evidence and created recommendations around that, they being this group that worked on this paper. And they found some avenues for future research. They found some things that maybe were pretty clear that we should maybe be doing, and then some things that maybe were less clear. And then some ideas about maybe where to focus some of that research to gain the most, you know, bang for our buck, so to speak. And so looking at this paper specifically, they looked at 13 systematic reviews. And remember, each of these systematic reviews looked at randomized control trials on their topic. So each one of those systematic reviews were included in this review, in this analysis. So they identified 20 risk factors from all these reviews that they looked at, and they evaluated them based on a grading system with a level of 1 through 5, with 1 being the highest grade, so consider 1 an A, basically. And then they created a recommendation grade, either A or B, which is strong or weak, based on what the evidence supported for that particular topic. So we'll dig into that. This will make more sense. So the risk factors they came up with, and again, this was from analyzing a big pile of data, what they came up with and pulled out of there were bedside operations and intubation care. We'll talk about sort of what went into that one. Agitation and irritability of the patient that's intubated. Poor fixation of the tube, and we're going to talk about that. Night shift, which we kind of mentioned briefly for all the reasons that we talked about, that night shift may create a bit of a higher challenge. 1 hour before and 1 hour after shift change. So if you work in the ICU, you sort of understand that time frame. So the previous shift is trying to wind down. They're wanting to get out on time, so they're trying to get everything done, right? They're trying to get their charting done. They're trying to figure out their report that they're going to hand off to the next shift. So maybe their focus isn't fully as much on the patients and as much on the detail stuff as it was the other 11 hours of their shift. Same with getting started. You know, when you start your shift, you're trying to get organized, you're figuring out where you want to go first, you're kind of, you know, maybe looking through your electronic medical record to see if there's anything that you didn't get in report. So all these things, again, you're not fully focused on getting moving yet. So it makes sense to me as somebody who's worked 20 years in the ICU that time frame would be challenging. The ventilator withdrawal stage makes sense. Our sedation is off, or at least at a very, very low level. The patient is as awake as they are going to be, and we've turned down the vent support. So that creates an environment where they're at very high risk. Patient who is male, confused, and has a high GCS. That's specific and sort of talks about some of the ones we've already talked about. So in other words, they're pretty with it. That would give them a high GCS, but they're confused, maybe because some residual sedation, maybe because when they got put on the vent, it was Sunday, now it's Thursday, and they have no idea where 5 days went, things like that. And then we talked about, you know, being male, being a risk factor. Monitoring nurse to patient ratio and physical restraints. Again, the restraint was a little weird for me, but we'll talk about kind of how that makes sense. Nurse to patient ratio makes perfect sense for anybody that's been in the ICU. If you're monitoring 4 vented patients, you're going to have a hard time keeping up with what's going on with 4 of them, more so than if you had 1 or 2, right? So it makes sense. And then just monitoring in general. What sort of environment is your ICU? Is it a very acutely monitored unit? Are there lots of, is there lots of technology, cameras, alarms, things that are making you aware and focused on what's happening? Or is it maybe a little more lightly monitored where you have to be like in the room to see certain things? Depends on your ICU maybe. All right, so bedside operations and intubation care, digging into that one specifically. Think about things we have to do to a normal ventilated patient just in the course of our average workday. We have to turn them. Again, skin breakdown, all these other things, we have to think about that. So if we turn them, if we're not paying attention to the vent tubing, to the securement device, to some of the other tubes and wires that may be around the tube, we may miss something, and that may cause the tube to be dislodged. Oral care, we're maybe moving the tube out of our way, kind of getting in there with our toothbrush or our swab. We may bump something loose that way. Whenever we have to manipulate the ET tube, so most institutions have some sort of policy, mine included, where every so often that tube has to be jostled from one side of the mouth to the other so that it's not hitting the same part of the lip. So that has to be done. And if I'm manipulating the tube, there's a chance I could dislodge it. Suctioning, again, if my suction catheter gets hung up inside the tube, things like that can happen. It's not common, but it can happen. And then anytime I have to change the securement device, my institution, and I can't speak for all of them, but my institution, the securement device gets changed every 7 days at maximum. Some of them get changed more often than that, but at the very least, they get changed every 7 days. So that means once every 7 days, if the patient's intubated that long, that entire securement device comes off where the tube is not secured at all. A skin assessment is performed, and then a new securement device is applied. So obviously that is going to create a very high risk of the tube coming out if you're not operating safely in that environment. So these are just some things that just part of normal care of the vented patient can result in tube dislodgement. Agitation and irritability, this should be pretty intuitive. If the patient's agitated and flopping all over the bed and not redirectable, they're going to be at higher risk, right? So because minimizing sedation has become such a common practice, as we talked about, that creates that potential for agitation and irritability that maybe didn't exist, 10 years ago, certainly 20 years ago. Sedation has been known to cause or worsen states of delirium. Again, this is for patients that are not completely comatose with sedation. They're in that sort of middle area, that sort of what we might call the twilight state, where they're sort of out of it, but not fully out. So the use of targeted sedation scales, you might use the RASS, you may use some of the other ones that exist out there. We use the RASS scale at my hospital, and that's the one I'm most familiar with. Doesn't mean it's the only one, but it's one that I've had experience with. And it gives you a guide of sort of where to target your sedation. So using something along those lines, along with close monitoring of how the sedation is affecting the patient, has been the best metric of having a better outcome, sedation related. We're going to talk about this one in a bit more detail, the fixation of the endotracheal tube. So how do we keep the tube in place, and what sort of device and what sort of strategy do we use there? And I can tell you that the data, and I did a fairly deep dive, the data does not really favor any sort of securement strategy over another. There's not like a magic bullet that says if you secure the tube this way, you're never going to have an issue. That's part of our research gap, is maybe there is something that's more effective and we just have not proven that in the data yet. But as we sit here today, there's really nothing that's supported by the data that says this device is the one everybody should use if they don't want the tubes to come out. There's a variety of options that exist, and from what I've seen and from what I've read, all of them have pros and cons related to them. Practices vary widely. Because there's so many options, there's a lot of choices that institutions and departments can choose to utilize to secure their tubes. Commercially available securement devices, along with just good old-fashioned taping, there's a lot of options, and we'll talk about that. Commercial securing devices, so there's a variety of these. If you've ever been to a respiratory conference and walked through the vendor hall, you'll get dizzy with all the different options. And if you've been in the medical field for any length of time and you've developed a relationship with your vendors, you'll know that they all will tell you all the great things about their device. And there are definitely positives about all of them, and I've worked with a variety of them in one way or another as a clinician. And just some sort of, I guess, generalized things about commercial securement devices. Most of them are pretty easy to use. They design them that way for a reason, to make them easy to use for the clinicians that are going to be using them, which means there should be a minimal training and learning curve for those clinicians. Some allow for very easy repositioning. They just have like a little button you can push that releases, and you can slide the tube back and forth, different things like that. Some of them are designed to try to minimize lip and skin irritation. Certain devices per manufacturer guidelines can be used up to 30 days. I will say that institutional guidelines might differ from manufacturer guidelines. Even if a manufacturer gave us a device that was good for 30 days, we'd still change them every 7 because we want to do our skin assessments. So your institutional guidelines would guide that practice either way. And because there's so many different options, each of them have advantages and disadvantages. And so I will say that I've had pretty good luck with the ones that I have worked with. One of the things I will say, and I mentioned this later on in the talk as well, is that you should really be universal with your approach. Make sure your staff doesn't have 20 different things to learn and figure out and sort of choose between. Have an approach that you use in your institution that you like, that gives you the best outcomes, and just have that be your practice, and make sure that all your staff are trained up on that device and how that device works. That would be my best take home there. We can always tape. Taping, I think because there's so many securement devices available, taping is pretty uncommon these days. Won't say it doesn't happen, but it's fairly uncommon. You can use many different kinds of tape. We say universal application because anybody's face can be taped if you choose to do that. There's many different ways to apply this. I've probably learned 10 different ways to wrap the tape around the tube and secure it to the face. And because there's so many different ways to tape, maybe different people do it differently, and it can lead to issues because of the variance in practice. Can be more challenging to reposition the tube because you have to literally untape everything, move the tube, and then retape everything. Not that it can't be done, it's just a bit more challenging and creates an environment that's more possible for errors. Lip and skin irritation is possible because the tape is not specifically designed to avoid it, so maybe there's a higher risk of that. And secretions can actually loosen the tape. If you get secretions around your lips and face and it gets under and kind of disengages the sticky part of the tape, I've seen that be an issue as well. So maybe more issue than you want to deal with. Night shift, we've kind of discussed this already. Some of the issues with working night shift, or being a patient on night shift. In many facilities, I can't say all, I can't speak to that, but in many facilities, I think there are fewer staff, especially in terms of physicians and specialists and people that could really deal with an airway emergency if one arose. Nurse to RT patient ratios may be higher. I know I've worked at places where, because it's presumed that the patients are going to be, are not going to need as much care at night, we're just going to kind of tuck them in and we'll reevaluate the next day. Maybe they can adjust their patient ratios a little bit. I've worked in a lot of RT departments that staff down by 1 or 2 from their day shift core staffing with the assumption that there's less maybe potentially work to do there. And many facilities will put their lesser experienced people on night shift because the experienced people want to go to days for work-life balance. So So there tends to be a bit higher percentage of less experienced providers, both from nursing and respiratory, that are working those night shifts. So all of those things may work together to put them at higher risk on nights. We talked about the hour before and hour after. These are your shift handoff times and your getting started times. You know, that you may be busy with end of shift tasks, getting your documentation updated, making sure your handoff to the next shift is ready to go. You may be more likely to be distracted because of that, and you may monitor slightly less closely, not because you're trying to, but just because it happens, that you're not paying as much attention to the individual patient as you might if you weren't trying to get finished up. The ventilator withdrawal stage, which would be that time when you're turning the sedation off and you are getting that patient potentially through the SBT and ready to extubate. At that point, your sedation is usually off or at an extremely low level. Patient is more awake at that point, and that may create that disorientation delirium situation. Your breathing trial is with less vent support than they were probably on before the breathing trial. So think about a patient that's already, a little bit delirious, a little bit confused. They lost 2 days, 4 days, 5 days being sedated on the ventilator, and now it's hard for them to breathe because they're breathing through a straw with very little support from the vent because we're trying to assess them for extubation. So this all kind of creates this environment where the patient is going to be more likely to freak out, get a little bit fidgety and maybe try to reach for the tube and all those things. So it's high risk time, and they should be closely monitored. So what can we do about all these things that we're talking about here? So psychological care and root cause analysis, this is one of the things that was cited here. In other words, can we redirect these patients? Can we sort of talk to them and sort of reach them mentally and say, hey, look, you're on the vent, things are going to happen here that are going to be uncomfortable. Let's try to talk you through it. And then root cause analysis is essentially just, if something happens, let's look at the situation and look at points of failure and see if we can come up with action plans to correct those. That's really sort of the 30,000 foot view of what root cause analysis is let's analyze when mistakes are made and let's try to see how we can avoid those in the future. Restraints, controversial. And again, some data that shows that restraining them may create more agitation because they can't move their arms. So we're not going to not restrain them when we're not in the room, but we may want to analyze that a little bit. Secure the ET tube with suitable fixation methods. Again, pick what you're going to do and do it, and make sure your staff is highly trained on applying, changing, troubleshooting these devices. Continuous quality improvement. Always look at what you're doing in your institution and what's working, what's not, and move forward. Management of sedation and the associated risk factors. We talked about that a little bit. All right, so what does this paper, what did they pull out related to each of these topics? So one of the analyses that they looked at for psychological care root cause analysis was this paper by Jan et al. In 2016. It was 8 randomized controlled trials, and it showed that psychological care reduced unplanned extubations. So it was a statistically significant improvement in anxiety, the degree of anxiety, hallucinations, depression, and desperation, and unplanned extubation. So what they found was focusing on that psychological care piece and reasoning with the patient and those types of things may show an advantage in decreasing unplanned extubations. Keep in mind, as I move through these in the next couple minutes, there's an understanding that some places may have more of an infrastructure in place to do more of these things than others, based on staffing, based on practices, based on the requirements of your staff. So these are just suggestions and ideas that are supported by the data if you're able to make those part of your practice. Restraints. So I'm not going to attempt these names because I don't want to mess them up and be disrespectful, but these 2 papers in 2014, they looked at restraints on ventilated patients, and in the case of the top one here, restraints, if their GCS was greater than 9, showed an increase by 6 times. So in other words, 6 times more unplanned extubations happened in that patient group, the group that was restrained with a higher GCS, than the other patients. That's interesting. recommended standardization of physical restraint and sedation management, and strengthened monitoring of the high-risk groups and time periods. So think about those time periods, night shift and an hour before, an hour after shift change. So maybe increasing your monitoring during those times, and figuring out sort of how to standardize what you're going to do with restraints, with sedation, and especially maybe specifically during the higher risk times. And then restraint alone was not effective, and relevant nursing interventions in conjunction with restraint were much more effective. So in other words, if you're going to restrain them, and we're going to restrain them for sure, in the ICU, we're going to restrain these patients for the most part, but we should also try to use the psychological care, also try to explain to them when they're awake enough to understand what we're saying, explain to them what's going on. Hey, like our nursing staff here, they like to say, hey, these are just a reminder not to reach for the tube. They're not really to hold your arms down. Maybe that just makes it easier for them to digest. Securing the ET tube with suitable fixation methods. That sounds kind of generalized, but again, Gardner in 2005, and there's been a couple individual papers, but understand, so if you know of some individual papers, remember this paper only looked at systematic reviews and meta-analyses. It didn't look at individual papers. So I was able to find a couple individual papers that spoke to this during the time frame they looked at, but they weren't meta-analyses or systematic reviews, so that's why they wouldn't be included here. But the review that they looked at in 2005 by Gardner and colleagues basically said we need more data, we need more research, we need to look at these stabilization methods to try to establish what should be best practice. And that there's a variety of factors, right? Cost, how effective are they? What is the time requirement of staff to apply them, change them, monitor them, care for them? Would also be of benefit, because we all work for businesses. Even nonprofit hospitals are still businesses, so cost matters. So some of these devices, even if they're effective, may be more expensive than what you're currently doing. So you have to be able to show that whatever they're going to bring to justify the higher cost is valuable. So these are all things to think about in your hospital. Continuous quality improvement. I think this is big no matter what we're talking about, but certainly unplanned extubation. So De Silva and Fonseca in 2012, quality improvement programs reduced unplanned extubations by up to 53%. That's a lot. The incidence after implementation of continuous quality improvement range from 0.1 to 2 per 100 intubation days. That's a pretty low incidence. These programs involved multiple interventions and focused on data collection, standardization of procedures, staff education, surveillance, and identification of the high-risk patients. Basically, if you know somebody's at very high risk, do something different with those patients. It all makes sense. Have a tracking tool. This is one we've used here in our pediatric ICU. We're not really focused on pediatrics here with this discussion, but certainly it happens there too. And this is one thing that our pediatric area used to try to get as much information as possible about each of these unplanned extubations to try to move forward with quality improvement. 2014, management of sedation and risk factors. Again, standardizing restraints and sedation, and especially monitoring high-risk groups and time periods. So to summarize their recommendations into a more condensed version, we need more research on psychological care. We need methods and pointers to be strictly mastered. We need more research on securing the endotracheal tube. We need to see if there's a way that, or a device or some sort of process that's maybe better than the rest. And we always need to have an eye on continuous quality improvement and root cause analysis. That should just be automatic. So what would a bundle look like? Just to kind of wrap all this up, what would a bundle look like if we were to build one, right? So we want to secure the tube. My take on this, based on the data we just talked about and based on some personal experiences, have some institutional guidelines and ensure universal practices, meaning ICU A and ICU B, we're going to secure the tube the same way. If we choose to use this particular securement method, that's what we do. That way I can competency my staff, I can train my staff, I can hold them accountable and make sure that those practices are being followed and that those devices are being optimally utilized. That should help me. Restraints. Make sure we have criteria for applying and monitoring, and we should assess the need very frequently. As soon as we don't need restraints anymore, we should get rid of them. Because again, we know from some of this data that they increase the risk of unplanned extubation. So have them when you need them, make sure you're consistently assessing whether you need them, and get rid of them when you can. Sedation, what do? Use disease-specific and patient-specific parameters, use some kind of a scale to monitor and titrate, and closely monitor them for delirium. What we see is it seems like the delirium part is the most challenging, because we have them on sedation, but because we're targeting these lighter levels, that puts them at higher risk for delirium, and the delirium in and of itself creates a risk factor. So we should monitor them for that, and if we identify that, what do we do about it? And we should have a plan for that. How do we monitor these patients? We should have staff members to monitor the airway during patient repositioning and any airway care. So you're going to have usually multiple people in the room, maybe a PCT, a patient care technician, or nurse assistant, respiratory, nursing. Somebody should be in charge of the ET tube, usually respiratory if they're involved, but especially on the higher risk patients. I can tell you on the really sick ones that are really tentative and tenuous, we'll have them call us so we can come to the bedside if they're going to do major turns or major cares or change the patient or whatever. We'll want to be there to help secure the airway. So that's one thing that we've done in terms of our quality improvement. If we have to reposition the ET tube, have another set of hands. Sometimes with staffing that's challenging, but to the point that you can, grab one of your friends, grab the PCT. All they have to do is say, hey, hold your hand here, pinch the CT tube, and don't move no matter what I do. It's better if someone's trained to do that, and you can have one of your RT friends if you're there, but have somebody there to help you secure the device. Don't try to do everything yourself. Psychological care seems like, based on the data, there's value here. So optimize that whenever the patient is not completely knocked out, especially at those high-risk times. Root cause analysis. Always do this. Root cause analysis. If something bad happens, analyze it. Come up with a quality improvement plan, analyze all of the data, and evaluate what you think will fix it, and do that. All right. In conclusion, unplanned extubations are a big problem in the ICU. We know this, and we've probably all experienced it if we've been in the ICU for any length of time. There's a lot of moving parts. There's a lot of factors that influence it. The main influencers seem to be, based on the data and probably based on some people's experience, securing the ET tube properly, management of sedation, the monitoring and around the staff to patient ratios, performing the airway cares, and are we doing that optimally, and the time of day and the time of the shift. These seem to be the big influencers there. Okay, so a care bundle that includes universal securement, careful airway care, sedation and delirium management, psychological care, along with quality improvement and root cause analysis, may provide value if we can get all those things together and make them all work. A lot more data seems to be needed. Certainly recent data, some of the papers that, some of the analyses that we looked at were from the early 2000s. So clearly we can relook at some of these things. Technology's different now with some of these devices. And so staff education, tube securement, psychological care, and certainly sedation and delirium. I'm going to close here. I'm going to turn this back over to Tyler, and we are happy to entertain whatever questions you guys have. Tyler, back to you.
Thank you, Andy, for that very informative session. I would like to now inform our viewers about how to obtain their CEs for this session. Again, this was approved continuing education for nurses and respiratory therapists. It's been approved for 1 contact hour. To obtain CE credits, go to www.saxtesting.com/P. You will need to register at the site, complete the evaluation, and upon successful completion, you'll be able to print your certificate of completion. Again, this activity was supported this was supported through an educational grant provided by Dale Medical. An archived version and on-demand version will be available on www.perspectivesinnursing.org. An email will be sent to all registrants when it is available. The on-demand version will be accredited for nurses and respiratory therapists. Okay, so now let's get to some questions. Again, thanks, Andy, for that presentation. We do have a few questions that are coming through here. And throughout your presentation, you talked a lot about some sensitive times in care and as being risk for extubations. One of which we did a lot of in the past few years was proning. So we have a question that came in from Neela Carney asking about, have you come across anything about increased incidence of endotracheal tube malposition or unplanned extubations when proning?
That is a fantastic question. I didn't really hit on proning. I think a lot of places are doing less of it now than we did in mid 2020, but it does still happen, and it's a great question. I can tell you that I will relate this back to a comment that I made where you just need to have enough hands to manage the airway. I can tell you here at our facility, and my partner Tyler here is one of the godfathers of prone positioning. He helped us design our process here, and I can tell you here we had almost no trouble with that, considering how many people we proned. It was hundreds and hundreds and hundreds of proning sessions, and we could count on one hand the number of tube dislodgements because we had a careful process in place that involved enough set of hands and people that were just dedicated to making sure the airway stayed in place, and that in our facility, those people were always respiratory therapists with training in airway care to make sure, and we all understood how the tube was secured, we all understood, and then we sort of dictated when the turns would happen so we could kind of brace ourselves and make sure that we were applying pressure to the tube in the right way. And so I guess my advice to you is, make sure that your institutional practices have caveats in place where when you're proning, there are dedicated airway people on the team, and ideally those people should be respiratory therapists that are trained in airway management to make sure that that tube stays in place despite all of the obvious movements that are going to be happening.
I think that's a fair point. Having the experts managing the airway was something that, again, we saw here helped out a lot. What about Stuart Ferguson sent out a question about endotracheal tubes themselves, and if you've seen in your experience or seen anything about the rigidity or lack thereof in endotracheal tubes these days becoming a little more flimsy, if that is playing a role in some of these unplanned extubations.
It's a good question, Stuart. I can tell you this. One of the things that I've seen, and maybe you guys have too, is once a patient's been on active humidification on a ventilator for a period of time, the heat and the humidity tends to weaken, I think, some of the integrity of some of these tubes, if that makes sense. So I think over time, the tubes tend to get a little more flimsy, even more so than when you start with them. I haven't personally seen, like, if they're only going to be intubated for a day, I haven't really seen the tube itself play a big role, but where I've really seen it is in those situations where it's like day 8 or 9, and they've been on active humidification the whole time, and that tube has weakened and become more flimsy because of the heat and the humidity warping the integrity a bit.
Sounds good. All right, we have time for one more question. Someone has asked, Erica Miller, do you recommend daily x-rays to confirm, that your tube is in the appropriate spot?
I think that's a good question. I think that I think that depends a lot on how you're choosing to secure your tubes. Most of the securement devices that I've personally worked with secure the tube in such a way that it's pretty easy to assess where that tube is at the teeth or the lip or whatever you're using as your fixation sort of place. So if you're going to chart this tube's at 25 at the lip and you have a securement device that it's very easy to see that that's exactly where it is, I think that minimizes the need for daily x-rays, and especially in this landscape of cost, if that's the only thing you're using to justify getting an x-ray is, I want to make sure the tube's still okay, I think it's hard to justify that. I think where that comes into play is if you use a device that requires you to tape around the tube where you would normally be able to look and see where it is at the lip. That becomes more challenging because then you don't have that sort of fixed point to look at and say, yes, I know the tube's in the same place it was earlier in my shift. So I think more than getting daily x-rays, perhaps examine what your institutional guidelines are for securing the tubes and make sure you're using something that makes it very easy to assess where that tube is always at in relation to the patient's anatomical landmarks.
Yeah, I think that's fair. Or even if you have one of the devices where you can't see that clear mark, maybe making a mark yourself to signify
good idea
where it should be. So that is all, unfortunately, all the questions we could take. There's a lot of questions online, but again, Andy gave his information. You can reach out to him.
Please feel free. I'm sorry, Tyler, please feel free to email me with any questions if there's anything I can do to help. If I don't have the answer readily, I will figure it out for you. I will reach out to my network if I need to. Tyler and some of the other people in my network, I'll get you an answer. If you have a question that's really weighing on your mind, please feel free to reach out.
All right, so thank you all for attending this webinar. There is a survey that immediately upon the conclusion of this webinar, you will be presented with this survey. Please keep your web browser open. We appreciate your feedback. And CE certificate completion, and 1 hour following the conclusion of this webinar, you will receive an email with instructions and the link below to obtain your CE credits. That is www.saxtesting.com/P.
Thank you, Tyler, and thank you, Andrew, for such a great presentation. Again, as Tyler said, immediately upon the conclusion of this webinar, you'll be presented with an online survey. We thank everyone for joining today, and we hope everyone has a great rest of your day. This concludes the session.